Hello, my name is Carla Farkas, and today I'll be presenting a case of an acute headache in a 37-year-old patient, Mr. D. Mr. D is a 37-year-old man who presented for an urgent assessment due to a headache that began approximately 24 hours ago. He has a known history of migraines, which he typically experiences a few times a year. Mr. D was in his usual state of good health when yesterday morning he woke up with the sudden onset of a headache. The pain gradually worsened over the next few hours. Fortunately, because he works from home as a graphic designer, he was able to rest in a dark room, apply a cold compress, and take some ibuprofen. These interventions provided partial relief. He described the pain as throbbing and heavy, localized primarily to the right side of his head and behind his right eye. The headache has been intermittent over the last 24 hours and reached a severity of 8 out of 10 at its peak. Associated symptoms include nausea and photophobia, but notably there was no vomiting, no visual aura or changes, and no sensory or motor disturbances. Mr. D does have a well-documented history of migraines diagnosed in his early 20s, which typically occur 2 to 3 times a year, often during seasonal changes. His usual approach is to treat them at home with rest, darkness, and over-the-counter medication. This episode, while slightly more prolonged, appears similar in its pattern to his previous migraines. So onset was sudden, yesterday morning. Location, right side of the head and behind the eyes. Duration, intermittent over 24 hours. Character, throbbing, heavy. Aggravating factors, bright light. Relieving factors, darkness, cold compress, and ibuprofen. Associated symptoms, nausea, photophobia. Timing, intermittent episodes throughout the day, and severity peaked at 8 out of 10. In terms of positives, he has right-sided headache with photophobia, improvement with typical migraine strategies, as well as a personal and family history of migraines. Importantly, he denies any fever, neck stiffness, confusion, weakness, vision loss, or trauma. There are also no recent illness or exposure to sick contacts. Medications and allergies. He takes ibuprofen 400 milligrams as needed for headache relief and Reactin 10 milligrams daily during the spring for seasonal allergies. He denies taking any other medications, supplements, or herbal products and has no known drug allergies. Past medical history includes migraines diagnosed in his 20s and seasonal allergic rhinitis. Family history: his mother also has migraines. His father has hypertension and type 2 diabetes. Mr. D lives with his wife and 2 children in a stable household. He denies smoking or illicit drug use and drinks socially, usually 2 to 3 drinks on weekends. Objective, physical exam and findings. On general assessment, Mr. D appeared well groomed and appropriately dressed, but noticeably uncomfortable due to pain. He was alert and oriented to person, place, and time. Vital signs were stable: blood pressure 123/74, MAP of 90, heart rate 80 beats per minute, temperature 36.5 degrees Celsius, respiratory rate of 18, and oxygen saturation 99% on room air. In terms of neurological exam, pupils were equal and reactive bilaterally. Cranial nerves 2 to 8 were intact. No focal or sensory deficits, normal grip strengths bilaterally, no signs of stroke, negative meningeal signs, no nuchal rigidity, Kernig's or Brudzinski signs. HEENT exam, no sinus tenderness, normal fundoscopic exam with no signs of papilledema. He denies nasal congestion or visual changes. GI, does admit to mild nausea but denies vomiting. Abdomen was soft and non-tender. Other symptoms were unremarkable. In summary, Mr. D is a 37-year-old man with a known history of migraines who presents with a 24-hour history of a right-sided throbbing headache radiating to the right eye. The headache was associated with photophobia and nausea and responded to ibuprofen and typical home-based strategies such as rest and reduced light exposure. This presentation is consistent with his prior migraine episodes, although it has been slightly more prolonged. Importantly, he shows no red flag features such as fever, neurological deficits, trauma, or new pattern of headache that would suggest a more urgent or secondary cause. This case appears to represent an uncomplicated migraine reoccurrence, but continued observation and patient education on red flag symptoms would be important, particularly if the headache pattern continues to evolve. Thank you very much. Bye.